After you have given intravitreal injection, these patients will recover in a set manner. And I like Dr. Nayak to describe the sequence in which these patients recover so that we have correct information that the patient is recovering.
Actually, a few slides back, you yourself said that first thing that recovers is the visual acuity. And this is what even without you seeing patient, or you can even tell the patient to tell, say after 6 hours, ring up and tell what is the vision. So vision is the first thing which is going to recover. And then as it is written, probably it's the same sequence. The cornea clarity becomes next, and flare will reduce, cells in the anterior chamber will reduce, and vitreous is probably the last one, which takes maybe weeks to disappear. If it's not in plenty, it may take even a month, but at least if there are some cells and all, probably it will take few weeks.
All right, now I reach to a very important question that ordinarily you have given one dose of intravitreal antibiotic, a combination, and in 98 out of 100 patients, the response is very good at 48 hours. Now, once the response is not good, whether to repeat injection, Dr. Dinesh, and if you want to repeat the injection, what are the indications, or you don't want to repeat the injection?
I'll go a stage before this. You've given the injection today. You could have two situations. One is that you're within a setup which has a vitreous facility, also vitreous surgery facility, and the other is that you're working alone in a setup which does not have a facility for vitrectomy. If you're working alone in a setup which does not have complete facilities, you see the patient on day one. If there is evidence of improvement, it doesn't have to be that everything disappears, but there is evidence of improvement, whether the patient's pain has gone down, the reaction is going down, the vision is slightly better than before, the haze is a little less. If you see definitely some sign that the patient is improving, responding to your intravitreal, you may consider keeping this patient under your care. But if you do not see this definite evidence of improvement, please refer this patient to a vitreous surgeon immediately. I don't think today there is any place in this country which does not have a facility within 12 hours of driving where a vitreous facility is available.
So second injection is not advised by you?
So I do not believe there is any role of multiple intravitreal injections.
Of antibiotic.
Your patient is not responding, you are keeping on giving the same thing, you are actually going to harm this patient and take away whatever chance he had, and which was a very good chance of improving. So that very good chance you will remove.
You will like to repeat or go for vitrectomy?
In this era of microincision vitreous surgery, which is a pretty safe surgery, option is to go for vitrectomy. The only indication could be that, like he said, facilities are not available, or secondly, patient has a corneal abscess which prevents you to do vitrectomy, which you can't see. Because for vitrectomy you have to see and do it. So if there is a corneal abscess which is diffuse corneal abscess, then I would maybe repeat interview.
Yeah, but remember one thing, very often patients whom you consider that this is cornea is hazy, they will not be able to. Yeah, no. Why I am trying to point out, very often an anterior segment first surgeon will say, oh, इसमें तो haze है, corneal vitrectomy नहीं हो सकती. Not true. Most of these patients you can debride the cornea and do a vitrectomy.
That's right. Now coming to vitrectomy, first of all, I wish to share this concept which I get from phaco surgeons when they refer a patient. They said, "Badhiya vitrectomy kar di, sir." There is never a badhiya vitrectomy in endophthalmitis. It's not a reconstructive vitrectomy like you do for a macular hole or for a proliferative, say, diabetic retinopathy or for a retinal detachment. This is actually disrespect to term vitrectomy as it is commonly understood, that it is being applied to the procedure that we do for endophthalmitis. Because all we do by way of vitrectomy in infected eye is absolutely comparable to incision and drainage of an abscess. And the only purpose it serves, it reduces the vitreous volume, it reduces the load of bacterial toxins, it permits better drug penetration, allows you to inspect the retina, and makes available plenty of sample which you can send for culture. So disallow any respect in your mind for the term vitrectomy in endophthalmitis. It is a gross procedure wherein we just reduce the vitreous volume. With this introduction, I would like to know from Lalit that very categorically I need a very definite answer from him. What is your indication for doing vitrectomy when the patient has first presented to you? And what is your indication for vitrectomy after the patient has received the right dose of antibiotic?
If the vitreous load is too much, that means a patient of severe endophthalmitis, then at first presentation, provided cornea permits vitrectomy, I'll go ahead and do vitrectomy. Severe endophthalmitis, by definition, which I define is in the absence of, that exudates are extended right up to the ora serrata or they're touching retinal surface. That's a severe endophthalmitis. So this patient I will take up for vitreous surgery in the first course. Straight away. And second was after intraocular antibiotic. As I said previously, if patient does not show adequate response to first intraocular injection, then don't hesitate to do vitrectomy.
What will be your earliest stage to advise vitrectomy, Dr. Nayak?
Yes, definitely. I can only advise. I cannot do it. I will not do it. So I will refer it to retina surgeon in case, as Dinesh said earlier, that if after injection, if it is not improving and it's not showing any improvement, then definitely I will refer it, and probably that will be the stage where it should be done. Unless the advanced cases, of course, there's a first instance it has to be done. But in these cases where we expect some improvement, not showing improvement, then we will refer it.
Doctor, add a little.
Dr. Dinesh, the next question is coming to you. The basic point is what special precautions you would like to take. But I don't want to make them vitreous surgeons.
No,
I just want to.
Before we come to this point, one thing, because there is a misconception which is going around that the EVS said if it is PL positive, so vitrectomy has better results. If it is hand movements, then you should do an intravitreal first. Please be very clear. What did hand movements mean in the EVS? Hand movements in the EVS meant hand movements at 90 centimeters and the ability to be able to tell whether it's coming up and down or right and left. Therefore, that hand movements is something like counting fingers at 30 centimeters. So please, if a patient has gone down to a visual acuity of something like counting fingers at 30 centimeters, this is not a case for intravitreal. This is actually a case for a vitrectomy. So this is what, in terms of indications, please consider that you are not taking a case who needs an intravitreal. It's a case who needs a vitrectomy. Now, as far as vitrectomy precautions are needed. Now, this is not for the objective is not to teach you vitrectomy.
One point.
But the vitrectomy in patients who are going in for endophthalmitis vitrectomy, they have a very boggy choroid. So you basically, that is why when we used to use a 20 gauge, we used to use a 6 millimeter cannula. But now the important thing here is you don't put it at an angle, you put it straight down. Otherwise, you'll be left in the choroid only. The infusion has to be put straight down vertically. Unlike the conventional 23 gauge ports which are made at an angle like a valvular incision.
And what should be the cutting rate?
The cutting rate should be as high as possible with that machine. The suction should be on the lowest possible with this. Objective is to put as little traction as possible. So, and the more important thing is not to use an old cutter. The tendency is ये cutter तो waste जाएगा, तो ऐसे करते हैं जो पुराना cutter है उसको use करते हैं.
Alright, then you use new cutter. Next.
As far as the cleaning is concerned, now the important thing is, previously there was a concept you just do a little cleaning and that's enough. Today the concept is you clean as well as you can.
Or as much as you can.
With safety. You combine safety with cleaning of as much vitreous gel as you can, reducing the load to the maximum possible.
What are the drugs you use?
And at the end of the vitrectomy, we give a complete intravitreal and we do not reduce the dose in these cases.
Now, this I think everybody is now switched off to 23, 25 and 27 type of a vitrectomy. So I think this is, everybody is going in for that. Whatever gauze you use, the results are the same. So what is the best in your hand that you can use, 23, 25, 27, whatever is there.
27 I would not recommend for anything.
Yeah, I would also not recommend. I would say 23.
23.
Yeah. 20 I will not recommend because so much of congestion will be caused that it will confuse your clinical picture when assessing post-operative recovery. Now, this is an important issue which I wish to actually take information from Dr. Nayak. They say that intraocular lens should be removed. Now that is the thing that phacosurgeon actually targeted. That was the whole thing that he does, that is putting an intraocular lens. Then they recommended that you should inject antibiotic in the capsular bag also. Some people advise that it is enough to do a posterior capsulotomy, you need not remove the intraocular lens. And in literature, some people advise that you take out the whole capsulozonular assembly. Now what you should do in different situations, Dr. Nayak, to comment please.
No, in most of the patients in endophthalmitis, there is no need to remove lenses, intraocular lenses. As against the basic principle of any implant, if it got infected, it should be removed. So, not the case over here. As Dr. Dubey said, that if there is a posterior posterior capsulotomy, posterior capsule should be removed so that the antibiotic can gain into the sac, into the capsular bag. Apart from that, if it is chronic, then again these things should be done, the posterior capsulotomy. And only in cases if it is fungal infection or recurrent infection, endophthalmitis or propionibacterium, then in these patients intraocular lenses should be removed.
Only the lens or the entire capsule?
Entire system should be removed.
Lalit?
Yeah.
Mild indications of removal of IOL in mild patient, mild endophthalmitis, I don't remove IOL at all. But indication of removal of IOL are recurrent, persistent, fungal or P. acne. These patients IOL should be.
I think I would agree. I would agree.
So routinely it is not to be removed.
Routinely we would not.
But posterior capsulotomy is to be done
Posterior
routinely.
capsulotomy should be done.
Now will you quickly comment, Lalit, general outcome, Dinesh, immediate complications, Dr. Nayak, late complications, and Lalit, indications for resurgery?
Resurgery, let's start from the bottom. Resurgery is required in patients where you have done vitrectomy, provided you have not tackled the hyaloid phase very well. If there are subhyaloid pockets of pus, then it may have a recurrence. And if you have not indented and you have left some exudates near the ciliary body area, again you may have recurrence. So resurgery again should be done pretty
In
fast.
your experience, how often you have to do resurgery?
Say around 5-10%.
5-10%.
Very less.
Okay.
And general outcome, anatomical outcome is pretty good. Maybe around 80% patients will, do pretty okay if I have taken care to do a complete job. Functional outcome, difference between anatomical and functional will be around 15-20%.
Dinesh, immediate complications?
I think when I do a vitrectomy, the first thing that scares me when I open the bandage is, will I see a white glow again?